All right. Hi, everybody, and welcome to Ladies Lunch and Learn. Thank you all for being here. Happy Thursday. And really excited to have you here with us. So there's the poll on the chat side. So you can let us know who's in the room, if you're a hospital, an FQHC, one of the other grantee types, contract pharmacy, or 340B friends and family. You're also welcome to introduce yourself in the chat. And today we have Jennifer Cinquenetti with us, who is a good friend of mine and also director of pharmacy at Valley Health. And they are a federally, sorry, 1 second. Gonna get right back to the start. Everybody look away for a second because you're gonna see the slides backwards. It's just as she is the director of pharmacy at Valley Health Partners, and she's going to be sharing with us on talking about using decision support order sets in primary care. And so we're very familiar with using these in the hospital setting, or at least that's where I'm most familiar with seeing them. But primary care, this is definitely an opportunity for us to expand what we're doing and take some lessons from the hospital area and pull them over into primary care. So looks like today we've got a lot of our attendees are from the FQHC space, then hospitals coming in second. Awesome job, guys. And then 340B friends and family, contract pharmacies, and some other grantees as well. So Jennifer, we're going to jump over to our fun poll. And this is Jennifer's poll question, and she was ready. When we did our pre-meeting planning, she had it all. She knew exactly what she was going to ask. And so just looking to see what people's favorite fall activity is. So Jennifer, what's your favorite fall activity?
I'm gonna have to go with hay rides. Like going
Nice.
out with the kids and seeing the fields and what's going on and just getting some fresh air.
Awesome. I am a big fan of trick-or-treating, and my kids are out of the house, but anytime I can tag along with people who have little children, I am a chronic volunteer because I'm a candy snatcher, but I also just love to see the little people dressed up. So that's my favorite. And then as far as the poll goes, trick-or-treating is number 2 behind football. So that is a really great one too. Pumpkin spice lattes coming in third. Awesome. So Jennifer, I will let you take it from here.
Okay, good morning, everybody. This is the outline for today. We're going to go over what clinical decision support is, how LVHN and VHP have used these tools, how to build these tools, and evaluating the data that comes from using all these click boxes.
As far as just one more survey before we get started, are you using clinical decision support in your medical record? And it's okay if you're not sure too. So if you're not sure, by the end of this, you should be fully aware of what clinical decision support is and be able to answer that. So it looks like most people aren't sure, and there are a few people in the room who are.
Very good. All right, yeah, so by the end of the review here, we'll have all these people that are not sure ready to go and get it. Okay, so just a little background on the relationship between Valley Health Partners and Lehigh Valley Health Network. So Lehigh Valley Health Network, all right, let's start with Valley Health Partners. So we're a FQHC lookalike in Allentown, Pennsylvania. We provide primary, pediatric, women's health, dental, vision, and chiropractic care. We just opened in 2021 with 7 clinics, all located within a 1-city block radius. Since then, we've added 6 additional clinics, including 2 school-based clinic sites. Our 340B program just started over a year ago, and we've already had $1 million savings in the first fiscal year. And we have almost 60 contract pharmacies that we use for our 340B program. Lehigh Valley Health Network is comprised of 13 hospital campuses and numerous health centers, physician practices, rehab locations, express care sites, and other outpatient care locations in 10 eastern Pennsylvania counties. So we're sort of between the Poconos and Philadelphia, although we are expanding into both of those areas pretty rapidly. Valley Health Partner shares one of LVHN's hospital campuses down here at 17th Street in Allentown. It's the site of the former Allentown Hospital, which was the first hospital in our area, and located in a residential area adjacent to the Allentown Fairgrounds in the center of the city. So our clinics that we had actually spun off from LVHN and were initially LVHN clinics. So as a result of that, we have continued to use Lehigh Valley Health Network for services, including IT and their EMR with Epic. We have direct referrals between our providers at VHP and LVHN. We use their express care services, their specialists. Probably 85% of our patients go to LVHN specialists. The acute care hospitals, a lot of our patients go to, and home and health rehab services they have. And then we provide, as I mentioned, the dental, vision, primary care. We have behavioral health services. We have a huge veteran support program, a wonderful street medicine program where we have clinicians that go out daily on rounds and meet at different mission sites or shelters or just out in the field. Also women's health, and then we have our enabling services and community referrals that we do with our community health workers where they go out in the community and work with the patients. So it's been a really good relationship because LVHN knows that we have a nice clinic over here. So if they have somebody that comes into the hospital, they can refer to us for patients that are uninsured or underinsured and helping address those issues for the patients. So as I mentioned, we both use the Epic EMR system. LVHN actually went live with Epic in 2015 for both its hospitals and provider practice locations. There's many active modules of Epic that we have, including ambulatory, Cadence, Willow, which is the pharmacy module, Cupid for cardiology, Stork for mother and baby, Wisdom for dental. They had all such fun names, and Beacon for oncology. So we use their Epic license for patient care as part of a service agreement between the two entities. And so this allows VHP to place those direct referrals. They go electronically right to the provider. We get our notes back, really great for our referral system and capture. And so in reviewing the documentation for office visits and through Care Everywhere, that we have visibility into several other local health systems as well. So as LVHN built their clinical decision support in the EMR, first they started with some condition-specific order sets. So these were just lists of medications, hypertension medications. You had every ACE inhibitor and calcium channel blocker and beta blocker and all in there. And some best practice advisories. So it would flag the providers when they were overdue for a colonoscopy or something like that. They started development of what we call care pathways. And so this was care as it was going from outpatient to inpatient and back, and sort of so everybody was on the same page and knew what was going to happen when the patient was inpatient and what would happen at follow-up outpatient. As part of that, we've built what we call our super smart sets. So these super smart sets are able to bring in data from the EMR, patient-specific data, what their creatinine is, what their what other medications they're on, what other comorbidities they have to help make and flag the medications and lab tests that they would need that would be most appropriate for that patient. And then sort of as the result of that, and we'll talk about towards the end, is we've built some Tableau dashboards. And so these are helpful in analyzing the data, not only what we're using for the order set, but following patients in readmissions and ED visits and where they're coming from, if they're on the right medications. And so we can go through that a little bit at the end. Okay, so what is clinical decision support? So CDS provides clinicians, staff, patients, or other individuals with knowledge and person-specific information. It's filtered and presented at appropriate times, and it enhances the patient's health and the health care the patient receives. There's many benefits, including increased quality of care and enhanced health outcomes. Making sure patients are on the right meds is going to make sure that they're staying well. avoidance of errors and adverse events. So there's messages that pop up if a patient has poor renal function to make sure we're doing correct dosing and things like that. And also improved efficiency, cost benefit, and provider and patient satisfaction. So if a provider knows that all the orders that I need for diabetes are in one order set, they can go right there and they know it's going to provide them the information they need to treat their patient best. There's been numerous studies that have shown that clinical decision support tools in electronic health records can enhance care quality by providing clinical information to care teams, along with those suggestions of evidence-based actions for patient care. So there's different kinds of tools that are built into decision support. So there's those best practice advisories, and those are the little pop-ups and reminders. You can build in the clinical guidelines as a reference. So, just as if you pull up the hypertension order set, we can pull in the hypertension guidelines and keep those up to date. The condition specific order sets, which is what I'm going to talk about today. And also as you're pulling through data, you can have reports and summaries that are actionable, documentation templates. So most of our provider groups, including our pharmacists, have specific documentation templates that pull in that data also right into our note. And so it makes it easier for, not spending all day charting. Diagnostic support, which tests the order. And then also, making sure they have relevant reference information, and we'll pull out those the information that they need right there in the order. So as we mentioned, they have been used inpatient for a long time. Things like sepsis warnings, order sets for surgery prep, asthma, ED and hospital admission orders, and also our maternal unit uses it for opioid use disorder treatment orders. And so the orders are all built in there. Outpatient, we started with diabetes, have gone on to hypertension, heart failure, GERD, and hopefully soon asthma, COPD, and bronchitis. You want to make sure you pick areas that there's a great use of repeat orders that need patient-specific data, things like DVT treatment, where you need the patient's weight and renal function, asthma and COPD, so therapies based on their classification. So you can go right into the order set and say, my patient's a class 4, and these are the medicines that they should be on right there. There are some cautions in using clinical decision support tools. There's that alert fatigue, too many warnings or alarms that come up or have false positives, so the providers just tend to start to ignore them. Unfortunately, there's looking to have some regulation put onto these algorithms from the FDA and HHS. They're hoping to make these decision support tools improve quality and transparency for real-time decision making, want to help prevent bias. But with guidelines that update every year or more frequently and changes in therapy, so they'll be difficult to maintain if that sort of guidance comes along. And we need to start teaching providers how to use these algorithms. So as they're going through medical school and their education, reviewing how to use probability in reviewing information and reasoning, and starting in their preclinical education and continuing this throughout their clinical training. All right, so let's look at some specific uses that LVHN and VHP have put together. So, like I said, we started with the order sets, and those were just a list of medications that you could click in. It wasn't sorted out by class or anything, or have any other information to help the providers make decisions. The best practice advisories were sort of reminder tools that provided that decision support, and those were they popped up and had suggestions for possible treatments and warning against contraindications. And then we have our super smart set. So not only do these include medications, but also laboratory testing that's needed, referrals for specialists, orders for medical equipment or supplies if they're needed. The medication section of the orders have been reviewed by multiple clinicians, specialists, and primary care to make sure that the most appropriate agents are available for providers to order. They include taper directions for initiation or discontinuation of therapy. And in our GERD order set, we built in a discontinuation taper. In addition to clinical decision support to make the most appropriate drug selected based on patient-specific factors. So as I mentioned, kidney and liver function, their weight, SDOH, and if they're having difficulty affording medications, and reviewing for target doses. Our use of clinical decision support was to proactively influence providers' habits instead of reacting and ask them to make changes in therapy later. So if you are just using reports of what's coming out and you're saying, okay, you have put Mr. Smith on this medication, now you need to call him and ask him to change. There was some concerns about how the patients would perceive that. The providers weren't taking it well either, that they felt they were always being scored. So it allows we don't have to reach back out to the patient and that we want to change therapy. You can get to therapy goals quicker because you're putting them on the right medication at the right time at the start. And appropriate tests are scheduled for approved times. So it will automatically space out A1Cs every 3 months, or lipid panels once a year or twice a year as they needed. As I mentioned, all the orders for therapy are in one place. So all you have to do is type in diabetes, hypertension, and everything comes up right for them. And then with our Tableau dashboards, we can monitor and make sure providers are using it appropriately. I will say we have found that providers will use it at initial diagnosis, but don't return to it for changes in therapy, which is unfortunate because there is guidance on how to taper up and things like that. But that's our sort of our next step in these order sets.
Jennifer, how have you seen the physicians receive them in general? So have they been
The order sets?
Yeah, have they been engaged with them? Was it
Absolutely. Yeah. So most of these are built for the primary care providers, and so unfortunately in our area, getting into an endocrinologist, getting into a cardiologist, it can be 3 to 5 months on a wait list. And so having the primary providers be able to start therapy and make confident decisions that in what therapy they're choosing, they have really appreciated that they can get their patients there before they have to really get to the specialist. So
That's awesome.
So building the smart set. So you want to look at what disease state the smart set will want to manage and what providers will use the smart set. So as I said, most of ours are for primary care. And we do bring in specialists for advice and on what medications and what testing and whatever else that they need there. You want to have a champion. So each of our groups has a somebody who will stand up for it, provide the education as it's outgoing, as the smart set's starting up to the different groups of providers and things like that. So and then you want to build the team. So we have the providers, have a pharmacist, have patients from the Epic team and analytics as well, because they're going to be going through and evaluating on the Tableau dashboards. Patient education team. Most of our smart sets do have a patient education part where you click on it and it comes out with their after visit summary. Clinical education. So this isn't just for the providers, but also to teach the office staff how these are going to work, because sometimes there's some extra teaching for blood pressure monitoring and things like that the nurses and the other office team members can help with. You need a project manager. This is a big haul, and most of these are a year or more to put together. And then the quality team. So, as you're talking about all these disease states, you're talking that these are all going to affect quality measures. So that's other parts of the team that you want to have there as well. And orders to include in the smart sets, like I said, we have labs, referrals to specialists and other providers, medications, equipment supplies, the patient education, and also there's some billing codes in there as well. If you have to administer a vaccine, those are in there. And so the administration codes are built in there as well.
And Jennifer, we got a question from Sarah. She's wondering, do your order sets get approved by a committee prior to being put in production? It sounds like you've got a committee involved in their development, but are they also approved?
Yeah, so it all goes through the providers and the specialists. There is one provider that's sort of the oversees all the things that we're doing together, all the order sets that we're putting together, smart sets. And so they kind of give the final go, but we do have people that overlook it besides our committee. So.
And then we've got the poll question going, and it's asking if you have pharmacists involved in the building of your order sets. And looks like right now the majority of who are responding that are confident in what they are doing are saying yes, that pharmacists are involved in the building of their order sets. Some of them are saying no, and some are not sure, but about half of their people responding are saying yes, pharmacists are involved.
That's good to hear. It's an important viewpoint, and I will tell you, there's been a couple of times where I've had to, talk to the providers and be like, okay, well, let's talk about what the next steps are, and the whole deprescribing on the GERD smart set, they hadn't even thought about putting in there. So, while it's important to get them on and treat them, they shouldn't be on it long term. So we did add that in as well.
Awesome.
All right, so building out the medication orders. So you want to first decide on which medications should be included or excluded from the smart set. So the list of medications was usually developed by the clinical pharmacist and then reviewed with the providers. And then we looked at it and looked at what doses we should include and which regimens for taper or deprescribing. We also took into consideration, like, is this something that really is like step 3 or 4 that the specialist should be using and not the primary care? So we kind of took out some of those, which ones we knew were more commonly covered by formularies and patients' payers. So that was important as well. And then as we built out the clinical decision support, there were sections. First, there was a section for drug class. We had to look at which patient criteria to review for each class of medication, which sections would automatically open and close based on this specific criteria. So, for example, in our diabetes one, if it's a newly diagnosed patient, that metformin always opens right away. And unless the renal function's poor, then it doesn't, and it opens up the GLP-1s and the SGLT2. So it has all that information in there for them. There's also positive and negative comments when the orders are open. So, this patient should be on this medication because they have heart failure. This patient has renal failure. Don't use this medication in the appropriate colors. And then the individual medication orders with what the strength is, the directions, the quantity, and how many refills.
It's phenomenal. Have you done any building, Jennifer, to account for some of the manufacturer restrictions as you've been thinking about medications and coverage?
So we have not had anything 340B related built yet or into this. So the part to remember is this isn't just VHP that's going to be touching this. This is all also all of LVHN. So we haven't done that, but I actually was in a meeting yesterday that one of the providers asked, can we have a separate order set about what's available on 340B? And my hesitation in that one is the frequency at which these manufacturer restrictions change. And so to get back in there with the Epic team and the enterprise analytics team is difficult. Yeah, all the time. So it's unfortunate. That would be a wonderful tool to have, but maintaining it would be difficult. So this is an example of the wonderful spreadsheet that we had built. So it's examples of things that we had talked before. So there's the drug class. There's the open by default conditions. So the first one there, if the patient doesn't have any active medications for diabetes, if their metformin dose is less than 2,000 milligrams a day, and if their eGFR is greater than 45. And then there's the 2 columns there with the preferred verbiage and the warnings, and they're in the green and the red. And then after that is what will trigger those warnings and preferred information to pop up there. All right, and then as we move across the spreadsheet, this is sort of to the right of where that is, we have the individual drugs. And so we in our order sets only have regular metformin and regular XR metformin, not the non-osmotic, non-gastric expensive ones. So that was one of our big things. We wanted to make sure that we had financial input in this as well. So there's the directions there for both initiation and with the uptaper for the metformin, and then for the maintenance. So the providers could pick either of those from this smart set. So this is a patient screen as you're in Epic and your provider putting in orders. So if they put that diagnosis in on a visit on the right-hand side there for the diabetes, then on the left-hand side where the smart sets pop up, that diabetes smart pathway smart set opens right up for them, or is there available for them. And then they click on it. And when they click on it, it starts with these sets of orders. And so first thing is labs, and they have in-clinic labs, they have lab panels, and those would be when you order it now or in 3 months, 6 months, whenever you want to have the follow-up. There's miscellaneous labs, so things that aren't usual for diabetes follow-up, so more like an insulin level or things like that, where it's a little more in-depth. Supplies. So we have everything from alcohol swabs to CGMs to their syringes and pen needles, test strips, things like that. So that's all right there for the provider to order for the patient when they start as well. So then as we go into the medication sections, at the top of the medication section, when it opens, it does list those pertinent labs that are important to look at. So one is the patient's A1C, of course, and then the next two are their renal function GFR tests. We also pull in an ASCVD risk score because we also have in the order set the ACE inhibitors, ARBs, and the statins. So it's all there. So if a patient's diagnosed with diabetes, everything's right there for you to order right away. So this patient was a test patient that we didn't have any eGFR or built in there. It hadn't been done for a long time. So the next first warning is make sure before you start treatment, run a new lab test. So it's right there. And then, some other things about following B12 levels and things like that. And then the orders there with the click boxes. And then as you go down in the order set, as I mentioned, there's the statins broken down by moderate or high intensity, the ACEs and the ARBs, if they need those to be added on as well. Immunizations, we have their Hep B and their tetanus vaccine, so we make sure those get updated for the patients that need it. And then here are the patient education documents, and so these are pulled in from our patient education website that we use, and so we have English and Spanish picked here, but they do have other languages as well. That's just most frequently what we use. So all those are there, and as soon as you click on that box, that automatically builds into the patient's after visit summary so that they get to take that home with them. Now for our hypertension order set, we also have a sort of a timeline driven education system. So you're diagnosed with hypertension, and week 1 you get a email or a message in your MyChart from Epic that says we review this document, and it's what is hypertension, or it might be a video or something like that. Week 2 you might get how to take your blood pressure. Week 3 diet. So those types of things, and so it's a ongoing education program for the patient once they're at home.
And then we got a question, Jennifer,
Yeah.
in the chat, and it was asking about another software, another electronic health record. And I'm not expecting you to know this, but I was just going to answer for the group. It's specifically about ECW or eClinicalWorks, and asking if they have clinical decision support. And I'm not aware of if they do, but what I would suggest is that anybody who is in the webinar, if you don't have it as something that you're aware of in your electronic health record, that you ask you ask the supplier of your EHR, and if it's something that they don't do, that you encourage them to consider adding it to their functionalities, because what Jennifer is showing here is so helpful for the care team and delivering the care, and then so helpful for the patients in making sure that they get best possible care. And I know when I made the move from being in the hospital setting to being in primary care, our medical record didn't have this capability. And this was I guess it was probably 2012, and I kept, sort of wanting to bring this in. And so when Jennifer mentioned that she was doing it in primary care now, I was really excited to have her come share this work. So really important to encourage your medical records to add these types of functionalities, because if we don't ask for it, then they really don't have a reason to be thinking about adding them.
Right, right. Yeah, unfortunately, outside of the Epic world, I'm not too familiar with any of the other EMRs to see what they have to build. All right, so now once we have these order sets that are built, as I mentioned, we can take the data from these tools and use it for each disease state. And so we look at the population demographics. We have in Epic, they build registries, they're called, and so it has all the patients that have certain diagnoses. And so they will take that registry and build these dashboards to pull in those populations with what their demographics are, patients that aren't meeting goals or on appropriate therapy. They'll look at care gap metrics, ED utilization and hospital readmissions. They look at the order set usage. And so these dashboards are built so you can easily filter down to your practice, your provider, yourself, and be connected through the Tableau dashboard direct to the EHR for outreach. So a patient list might come up that you have these patients that have diabetes and heart failure and aren't on an SGLT2. And you can go right in there and look at that list of patients and start doing outreach immediately. Whether it's a provider, a pharmacist, other clinical office staff that makes these outreaches, that's up to the practice. But I will say that I've been in all three roles. So who's making that outreach? So it works well to have that connection right there. This is an example of our dashboard for the diabetes clinical pathway. And so you can see here just patients who are overdue for foot exam, that is built in to the order set as well. Eye exam, statin usage, and other, just a primary care visit and things like that.
And then this one is intended for people to just answer in the chat, but just thinking about your practice and where you're working, what different areas do you see that the clinical decision support tool might be helpful, might have the biggest impact in the areas that you're working in? And so I am in, when I'm not doing 340B, I do a lot of focus on the treatment of opioid use disorder. And so I love the thought of this type of clinical decision-making tool just for helping people remember all of the other primary care treatment for those patients, because a lot of times things like vaccination status gets forgotten, or testing for things like hepatitis C often gets overlooked. And so those are the types of things that are coming to mind for me with this type of decision support, as well as helping select what type of therapy might be best for those patients. And so Sarah has put in MTM clinics. She could see it being helpful. And Jennifer, what's your next area that you're thinking about adding a new tool for?
The respiratory diseases. That's been kind of the one I've been pushing for. So we're working on. We have the hypertension still going live. The GERD is still going live, and heart failure we're still updating. So that'll probably be a next step, I hope.
Yeah, and then Allison made the comment too, just seeing it being able to help with the primary care patients where there's difficulty getting into the specialists, especially for the beginning of their treatment for specialist based care, and absolutely agree with that. I think there's
that was one of the main reasons that we had started this. And we picked those disease states on purpose because getting into those providers was difficult. So
yeah. Hepatitis C management is another one that is so very really protocolized, that I could see something like this being really helpful, that if the labs are pulling back in, that it's something that can be managed in primary care, but it really requires the clinicians being empowered to start that work, and typically having pharmacists involved too is really helpful. But these types of order sets that help guide can be really really important in that as well.
Yep.
Awesome.
All right. So here's my contact information. Anybody that's on Epic, I can certainly help with questions there. And then references, if you want to have some support to go out there and build these in your clinics, there's some support there to have that going.
So thank
I
you
think
so
that's
much.
the end of me.
Thank you so much, Jennifer. You're welcome to stay up on stage and join in the conversation for the rest of this. And I know you're involved in lots of the things that are going on here, or if you want to jump off stage, you're welcome to do that too. That's fully up to you. But we're just going to switch gears. And if people have questions for Jennifer too, you're welcome to put those in the chat and we can bounce back to those. Rebecca's uploading the handouts that come with the remainder of the topics that we're going to talk about, but we'll just jump in. Since we talked last, 2 new manufacturer restrictions have come out. Jazz Pharmaceuticals and Insight are number 25 and 26. They are both exempting the grantees and applying the restrictions to hospitals. And so they're also both using the 340B ESP platform. Insight has the 40-mile radius on their restriction. So something to keep in mind. With Jazz Pharmaceuticals, the Epidiolex is a medication that's used for treating seizures. They have restricted their restriction is just to that one product. And then for Insight, the Upselera, it is for treating atopic dermatitis. So again, both of these manufacturers, it's not their whole formulary of products, but it is their 2 high dollar, high sales items that they've created the restrictions around. With positive updates, because we do have a positive update in the manufacturer restriction circle. Teva Pharmaceutical has exempted Arkansas from the covered entity restrictions. So originally, Teva had exempted Louisiana from their contract pharmacy restrictions, and then has subsequently removed Arkansas as well from the restrictions. And it's the reason Louisiana was first exempted was that their laws had really more teeth in it for imposing sanctions on the manufacturer and the way that the state could do that. However, now that Arkansas has their state starting to impose sanctions and has given covered entities the opportunity to begin reporting manufacturers for blocking access to their products, Teva has now included Arkansas in the exemption. Merck was the other manufacturer who has an exemption for both of those states. And what is different between Teva and Merck is Teva is not requiring data. They have just fully lifted the restrictions in those 2 states. So congratulations, if you are in Louisiana or in Arkansas, you have access to those products. If you are for Merck, you are still required to submit data through 340B ESP to restore your pricing. Sanofi, I feel like I've talked a lot about this to different people this month. They changed their process as of June 1st, but didn't tell any of us until the end of July. So that was exciting. And at the end of July, they let us know not what they did, but that they were that our purchases were not aligning with our utilizations. Upon further investigation, the cause of that was because Sanofi decided in June that they were going to no longer use consolidated replenishment models, or essentially allow you to accumulate at the chain level and replenish at the chain level. So as of June 1st, they have transitioned to a one-to-one system. It means that if you're using their medications at one pharmacy, that the accumulations for that pharmacy also must be purchased at that pharmacy. So everything that happened prior to them essentially letting us know that we were at the critical moment and everything had gone wrong because of the change of policy that people were not alerted to, has left a lot of covered entities in a situation where they now have negative accumulations that has meant loss of Sanofi pricing. So the bottom image is just a really simple representation of what's been happening. So essentially, if you were in a chain logic and you had accumulations occurring across your different pharmacies, you bought, in this case, 10 bottles from the multiple pharmacy accumulations at one store, but you only submitted for 7 bottles at that single store, then in the eyes of Sanofi, you still need to submit for 3 more bottles worth of prescription at that store to turn on purchasing. You will have positive accumulations at all of your other stores, and purchasing will still remain open at those other pharmacies where you accumulated but never purchased. But the stores where you had more purchases than accumulations, that is where you will lose access. Leaves us in a very difficult situation of how do we get this back? Not all of the TPAs are created equal in your visibility. And so ultimately what you need to do is show prescriptions at that pharmacy to count up to the number of utilizations that they are saying you have negative accumulations for. So for some of the TPAs, you can go in and essentially run a report that shows your missed opportunity, or they may call it a manufacturer report that you can do. For others, you may be able to see claims that were blocked from your program and upload that information. Others, you may have to work directly with your TPA to help them help you gain access to that information. But essentially, if you are in 340B ESP, there is a report that will show you your negative accumulations. And that's where you're going to go to find out how many units of whatever product it is for Sanofi do I need to get to count back up to that, that 0 level so that purchasing can be turned back on. And if I remember correctly, everything in pharmacy, just consider it 5 business days. I think their email said 5 business days for purchasing to be restored. But that would be from ESP getting that information and then telling the wholesaler. So, and Lacey's asking the question, this only applies to contract pharmacies. Yes, if you lose pricing at your Sanofi, for your Sanofi products, at your entity-owned pharmacy, first question I would be asking is, for some reason, does the wholesaler have your entity-owned pharmacy set up as a contract pharmacy on the way the account is set up? Because you should not be losing pricing to your entity-owned pharmacy. These restrictions are at the contract pharmacy level. Great question, Lacey. How is the sunshine down in Florida? All right, next topic is something that's different. It's West Virginia specific. So if there are any West Virginia people in the audience, this is very important for you. But it's also just a really novel idea. So Gainwell is a pharmacy benefit manager who is well known for working with different state Medicaid agencies. They are famous to me for managing the Oregon Medicaid model, which is one of the rebate or one of the retrospective models that allows covered entities to submit data on claims that they have processed at the covered entity pharmacies or at the contract pharmacies, and then alert Oregon so that they can prevent rebates from occurring. That does not tie to this, but that's just where I know Gainwell from. In this situation, though, they've come up with a really interesting solution for the state of West Virginia that may ultimately play out across the rest of the country. And so in West Virginia, what they have done is they have said that going forward after October 18th, you are only allowed to submit the submission clarification code 20 on prospective 340B claims submitted by pharmacies. And so they went back into the NCPDP guide. And in the NCPDP guide, it's very clear that the 20 code is intended for prospective identification of 340B claims. And so what also is very intuitive about this model is that the 08 is intended to identify when we're submitting a 340B price, but a 340B price is substantially different from a traditional WAC price. So in West Virginia's mind, they're saying if you submit the 340B price to us, we're going to be able to tell the difference between a 340B price and a non-340B price, and we're going to have the 20 code on it. It's going to tell us prospectively this is a 340B claim. But where it gets a little bit different is that West Virginia, through Gainwell, has decided that they're going to use the 08 to identify retrospective claims. So this is completely different because 08 used to be used to say, I'm giving you a 340B price. Now they're using 08 specifically to say, I'm retrospectively resubmitting this claim to you and telling you it is a 340B claim. We have not had a great way to retrospectively identify claims that are 340B. The N1 modifier that's mentioned on this slide was something that was proposed by NCPDP, but has not been adopted. And it was intended to be a retrospective submission code that you could use to identify 340B claims retrospectively. So this is absolutely going into effect for West Virginia, but we present it here as well as a possible solution for other states to consider to identify retrospective claims as well. So as we're thinking about, how do we move forward with being able to identify claims retrospectively, really unique solution, really low tech, and something that we already have the methodology for. So just putting that out there, just a really great way to use the system that we already have in place. And then Megan is asking, does it still require reversal and retransmission? Can the TPA attach the 08 on the back end? I'm not sure. And what I can do is I can field that question to Gainwell, but my assumption is that it would require the reversal resubmission, but I'm not 100% sure. So we can get some more information on that. So we will take that question and bring that back the next time. All right. Changing tack, because we always want you to be ready for what's coming. Inflation Reduction Act. I think we've talked a little bit about this before, and just making sure that everybody is keeping this in mind. So there are a number of pharmacy-related components in the Inflation Reduction Act, and there are a few that have 340B implications. And so within the Inflation Reduction Act, if manufacturers are raising their prices on their medications or biologics faster than the inflationary rate, then they have to pay penalties to Medicare. And so these penalties are similar to what we have in the 340B program that creates penny pricing. So because of that, it's going to be really important for Medicare to know when we have a 340B item that's billed to them so that they can, because they're only going to be able to get the rebate on these drugs when it's not a 340B item. So similar to Medicaid and 340B not being able to have a duplicate discount there, we're also not going to have the opportunity for Medicare to get a discount or get a rebate when we have a 340B discount. So because of that, we are going to have a way to identify our 340B drugs to Medicare. The hospitals have been doing this for years. There is also for manufacturers who choose not to comply with the rebate requirements and with the drug negotiation requirements, There are some penalties that will also be imposed on them, very heavy penalties that essentially encourage the manufacturers to participate. And there are 6 manufacturers currently who are suing the federal government to try to pause this. However, those are going to take a long time to play out in the court system. And because of that, we still want to make sure that we are ready for the 1st of January, because that's where our first requirement is going to come into play. So as far as January 1, the guidance that is currently out there says that we are required for the non-hospitals, the guidance currently states that the non-hospitals are to use the JG. The hospitals are have the opportunity to use the TB or the JG. And then there is proposed guidance that suggests that the JG will be phased out in 2025 for the hospitals. It's unclear if it will also be phased out for the non-hospitals. But as of January 1st, 2024, we are going to be required to identify on our medications that we are billing to Medicare these items. So if you haven't already started talking to your IS departments and you are a non-hospital in this room, this is something you want to be thinking about. For the FQHCs, your things to think about: IUDs, Bicillins, your injectables that you are billing for. Those are your most likely items that you want to think about. Okay, so just keep that on your radar. And then I'm just seeing a little bit of conversation in the chat. Amanda's mentioning that the hospitals have been doing this since 2017. Yes, you all are the experts in the room. This is very new for the non-hospitals. And then as far as Megan is saying, they've always left the modifiers off at the time of sale because we never know which ones are eligible. And then when we do a replenishment, so that's back to the previous conversation about identifying what's what. And burden of the pharmacist having to go back and reprocess with the modifier is crazy. Yes, it is. It's the life of the pharmacist. And just looking at in the Inflation Reduction Act, there is the negotiation of prices. And so what they're calling that is the maximum fair price. And as far as that maximum fair price negotiation goes, it really is going to be a phased approach. And so on the right side of the screen, there are the 10 drugs that have been selected for this year. And then each year going forward, they're going to be adding additional drugs that will be negotiated. And so interestingly enough, one of the manufacturers who had filed a lawsuit against the federal government, Astellas, actually withdrew their lawsuit because they were not in the 10 drugs selected. And so technically they cannot sue because they do not have harm that's going to come to them in the coming years, or in the most recent one upcoming, because they didn't get selected. So they weren't as special as they thought they were that time. So just kind of interesting. And Rihanna's saying that they jumped the gun. Yes. So, it's interesting. There was a lot of speculation on what would be on this list. And really, I think that there's some that people projected, some that there weren't. And then really just looking at how this is going to work, it's going to be that instead of getting the average sales price, as we would typically do, plus 6%, then we're going to only get the maximum fair price plus 6%. And for these negotiated drugs, there is so much to be determined, because a lot of these medications are actually going to go through the retail pharmacy. So we have great mechanisms for this to happen at the hospital level, right? For that billing to be adjusted. But how are we going to make sure that the retail pharmacies are getting getting the price that they should, or how is that money going to get back to Medicare? Is it truly going to be a rebate that goes to them? How are we going to identify this whole process? This is all to be determined. And then how do we identify the 340B drugs to Medicare as well, all to be determined. And so for the retail pharmacy side of this, it is going to be, we're waiting. There's a lot of discussion about, will we use a clearinghouse? CMS has been looking for input from different stakeholders as well. So this is very much to be determined. And so important is prepping for 2024, January 2024. This one, watchful waiting. And if you have great ideas, share them with the feds. And then just closing things out, really looking forward to upcoming sessions. I've seen Rhiannon in the chat. She's going to be doing advocacy update and a bit of a workshop. So next month, I want everybody come prepared to think about creating messaging that we'll be able to share about our organizations and the importance of our 340B program. So that one is really going to be, the initial part is going to be educational, but the second part is going to be a workshop, and hopefully everybody gets to develop something to be able to share. The following month, Lanika Ellis is going to be helping with developing self-auditing, so sharing information on that so people can develop their internal audit processes. And then in December, Michelle Fox and Connolly Key from Apexis are going to join us with Christmas presents. And so just sharing the different resources that Apexis has and how we can use them to help improve our 340B programs, and just talk about some of those tools that people often overlook that can be really helpful. And our last poll question: will you be attending the Fall Grantee Conference in St. Louis next week? I know probably our hospital people won't be there. Jennifer and I will be there. If you are attending, so we got 30 yeses. If you are attending and you have not received an invite to our event, we are hosting a reception at a speakeasy, and it is Roaring 20s themed, 20s attire optional. And so the challenge that we did have was that we only got conference attendees who approved sharing their email addresses. So if you did not receive an invite, you can either shoot me an email, and we can put my email in the chat. And we can send you an invitation, or Rebecca, if you want to put your email in the chat, they can email you and we can send you an invitation. Or if not, you'll see us at the conference, and we can give you an invitation there as well. So very much looking forward to seeing everybody in person. 32 people saying yes, so we will see you there. So Jennifer, any last words? Anything that we've, and then Rhiannon, you still have to find your 20s outfit. I am not surprised you were late booking your hotel room. Jennifer's got delayed in the mail, and we got feedback. Great job, Jennifer. It was fabulous.
Yes. Thank you.
Thank you for being here with us. So everybody, we look forward to seeing you in person in a few days. And if not, we will see you here next month. So thank you all, and have a wonderful rest of your day.
Have a good day.